So it's my pleasure to introduce the next speaker, Professor Riccardo Lencioni, who is in the field of hepatocellular carcinoma for quite a long time. He's an interventionalist, a radiologist doing interventions. He worked on TACE for a long time. He also was involved in many trials combining drugs with TACE. And we had here, probably you will allude to that, history of previous combination unfortunately didn't work. And now we have Immune-Oncology coming here. So really I cannot think of a better speaker to talk about this than you, Riccardo. Thank you very much to taking this task, combining TACE with Immune-Oncology.
Thank you very much, Jean-Francois. It's a great honor and a privilege to be here this afternoon. So first of all, good afternoon to everybody. I hope you can see my slides. The starting point, as Professor Dufour just mentioned, is coming from quite a few experimental data that suggested that could be a synergistic effect between local regional therapies, including TACE, but also ablation or Y90, and Immune-Oncology drugs. This has been supported by several experimental investigations over the past few years. And recently, a few phase 3 clinical trials were started, as you can see, mostly in the so-called intermediate stage, although the definitions were slightly different across the different studies. But in general, under the rationale of understanding whether the combination of local regional therapy, particularly with TACE, and Immune-Oncology combination was able to offer a clinically meaningful clinical benefit, which, as you know, was truly not the case of several prior trials conducted a few years ago, combining TACE with TKIs, trials that use the combination of TACE with sorafenib, TACE with brivanib, TACE with orantinib, and others. All these studies failed to show a clinically meaningful benefit associated with the combination. Now, the reason why I have highlighted the Emerald-1 study in this table is that this is the first trial for which results have been reported very recently, actually last month, at the ASCO GI. In this presentation concerning the outcomes of this phase 3 randomized placebo-controlled study of TACE combined with durvalumab with or without bevacizumab in patients with unresectable HCC eligible for embolization. You are very familiar with the background, so I'm not going to go into the details here. You know that TACE has been the standard of care for this patient population for more than 20 years, with very little progress, as I just mentioned, in several trials that attempted to improve the outcomes of TACE, particularly the tendency of the tumor to recur or progress. Typically, the PFS after TACE does not exceed 7 to 8 months in the best reported outcomes. So The trial, as just said, evaluated this hypothesis to be able to induce and enhance the anti-tumoral activity with the combination of TACE, immune checkpoint inhibition, and VEGF inhibition. The study population is, as I say, this mostly what we call intermediate stage HCC, so patients unsuitable for curative therapy, including resection, transplantation, ablation. No evidence of extrahepatic disease. However, as you can see, patients with limited branch portal vein invasion, so-called VP1 or VP2, were included in the study. So only patients with VP3 and VP4 were excluded. And this is, following the practice to offer TACE widely, particularly in Asia, in this patient population. In terms of general condition, liver functional status, the criteria are the usual trial criteria, so ECOG 0-1, child A to B7. As you can see, the overall 616 patients were randomized into 3 arms. So arm A was TACE plus durvalumab, followed by durvalumab and placebo. The arm B was TACE plus durvalumab, followed by durvalumab and bevacizumab. And arm C was the control arm, so this included the TACE and placebo, followed by placebo. The primary endpoint was progression-free survival for the arm B, so the combination of durva and bevacizumab versus the control using a blinded independent central review. And then there were a number of secondary endpoints. This slide shows a closer look to the study schema. So just to make it clear how treatment was administered. In short, there were 2 treatment phases. The first phase was the TACE period. So this was lasting up to 16 weeks. And during these 16 weeks, the investigators were allowed to deliver up to 4 TACE cycles with the number and the timing at the investigator discretion. Durvalumab, as you can see in the slide, was started at 1 week after the initiation of the first TACE, after the first TACE. So in this TACE period, as you can see, there was no bevacizumab administered in any of the treatment arms. In the second phase, the combination phase, then this second phase started after completion of the TACE cycles. And here we started the combination of durvalumab with bevacizumab or the relevant placebos. And treatment continued until PD or unacceptable toxicity or withdrawal of consent. The study planned for several analyses, as you can see, and at the data cutoff of September 23, the final PFS analysis and the interim OS analysis co-occurred. At this interim OS analysis, OS was not statistically significant. So the Emerald one, as per today, is still ongoing for the final analysis of OS and remains blinded to investigators and participants. Here you have the description of the patient journey across the different treatment arms. As you can see, most patients received 1 or 2 TACE cycles, and this is consistent with the prior studies, although there was 15 to 20% of the patients who received 3 procedures or even 4 TACE cycles during the TACE period. The number of those who reached the combination phase, as well as those still on treatment at the data cutoff, was very similar across the study. As you can see, there is also consistency in the percentage of patients who discontinue the study treatment, although discontinuation due to tumor progression, which was named as worsening of the condition under investigation, so the HCC. So this reason for discontinuation was lower in the combination of durvalumab and bevacizumab arm. This is the slide showing the baseline characteristics, and as you can see, the patient population is quite heterogeneous, so reflecting the heterogeneity of the TACE practice and embolization eligible patients in a global trial that recruited patients in North and South America, Europe, and Asia. As you can see, there was like 28% of the patients in BCLC stage A, and this is quite common in all the TACE series, so typically single tumors that for different reasons are considered unsuitable for surgery or ablation. Some 60% or so were intermediate stages, but around 15% of the patients were BCLC stage C, mostly, as I said before, because of the portal vein invasion, which you can see was present in reality in a minority of the patients. We are talking about 6-7% of the patients who had portal vein invasion. So 92-93% are the more kind of classic intermediate stage, at least looking at the tumor burden. In terms of the extent of the tumor burden, there were patients both within the up to 7 criteria. We are talking about around 50% or so of patients within the up to 7 criteria, as well as another 50% beyond the up to 7 criteria. So in this regard, the patient population reflected essentially both these scenarios of patients with relatively limited tumor burden or more extensive disease. This is the primary endpoint. So the slide shows progression-free survival for the combination of durvalumab, bevacizumab, and TACE versus placebo and TACE. As you can see, the curves of PFS start a clear separation around 4 or 5 months, and then the separation is maintained for more than 30 months. At the analysis of 12 and 18 months, there is a clear benefit associated with the combination arm. Looking at the median was 8.2 months in the placebo, the control arm. As I said, this is one of the best reported outcomes for TACE in the setting of a global RCT. And this median was improved by 6.8 months up to 15 months in the combination Durva-Bev and TACE. The hazard ratio was 0.77. Here you have the analysis of PFS in key subgroups. Of course, some of the subgroups are relatively small. I have highlighted the patients within the up to 7 criteria and beyond the up to 7 criteria, because as you can see, there seems to be a benefit in both these categories, so both patients with limited tumor burden as well as more extensive disease in terms of PFS. This is a secondary endpoint which was presented just a few days ago by Bruno Sangro at the Liver Cancer Summit. And this is the progression-free survival assessed in this case according to mRECIST instead of standard RECIST. We had planned for both criteria to be used in the study, with the standard RECIST being the one selected for the primary endpoint. However, as you can see, results are pretty consistent, and the benefit of the combination of Durva plus Bev plus TACE versus placebo plus TACE is confirmed in the PFS analysis, also conducted according to mRECIST. On the other hand, for durvalumab monotherapy, so for arm A versus arm C, as you can see, there is a modest improvement in PFS from 8.2 to 10 months. This was a secondary endpoint, and therefore, in this case, the PFS was not statistically significantly improved. Secondary endpoints included TTP, and again, the results of TTP in the Durva-Bev versus placebo on the left, and in the Durva monotherapy versus placebo on the right are consistent with the results that we have seen for PFS. So there was a statistically significant improvement in the combination TTP and a modest improvement with Durva monotherapy. In terms of response, this is the outcome of response according to RECIST 1.1, so standard RECIST. Response is higher in the Durva plus Bev, 43% versus 30% of TACE alone. Again, these figures are collected according to RECIST 1.1, but I also included the more recent presentation of the secondary endpoint of response according to mRECIST, probably more relevant to this scenario, particularly for patients undergoing TACE and placebo. As you can see, response for TACE alone was almost 50%, so again in line with the best reported outcomes, and was nevertheless higher with the combination of Durva and Bev to 60%. It's interesting to see that when looking at the quality of response, Clearly, with standard RECIST, we are mostly talking about partial responses, while with mRECIST, the combination of Durva, Bev, and TACE achieved, as I say, the 60% objective response with a 30% complete response, which is, I think, an interesting observation. In terms of duration of exposure to durvalumab or bevacizumab, given the longer PFS, also the exposure to the drugs was longest in the Durva plus Bev plus TACE arm as compared to the Durva monotherapy or the placebo arm. So this is something to bear in mind when looking at the safety and the adverse events. As you can see, patients in the combination arm experienced a higher rate of SAEs, grade 3-4 adverse events leading to discontinuation. Of interest, there were no adverse events with an outcome of death considered to be related to the treatment in the combination of durvalumab and bevacizumab treatment arm. In terms of treatment emergence adverse events, the profiles were generally consistent with the known safety profiles of durvalumab, bevacizumab, and TACE. As you can see, the most common event across all the arms was the post-embolization syndromes. Other adverse events are well-known adverse events associated with the drugs, hypertension, proteinuria, and so on. In terms of grade 3-4, again, there were no new or unexpected signals observed in the study. I wanted to highlight in particularly esophageal varices hemorrhage, because this is clearly something that is especially important in the setting of the combination durvalumab and bevacizumab. There were 4 patients who had a grade 3-4 hemorrhage from esophageal varices for 2.6%. 2 of these patients required treatment discontinuation. None resulted in death. As I say, there were no grade 5 considered to be related to treatment in the combination arm. So we concluded that the EMERALD-1 met its primary endpoint. So as such, is the first global phase 3 trial to demonstrate an improvement, a meaningful improvement in PFS with an immunotherapy-based regimen in this patient population of local regional HCC or unresectable HCC eligible for embolization. The median PFS was 15 months as compared to 8.2 months of the control arm, and the safety profile was generally manageable and consistent with the known safety profile of each individual therapy, TACE, durvalumab, and bevacizumab. So this regimen seems to have the potential to change the paradigm of treatment for local regional HCC and to set a new standard of care. Of course, more investigation is already ongoing, and particularly in addition to the trial that I presented at the beginning, there is now an EMERALD-3 trial up and running, combining the STRIDE treatment regimen with or without lenvatinib versus TACE, and particularly for the United States, where Y90 is currently a very popular option for intermediate patients, and many centers prioritize Y90 over TACE, and so the Emerald Y90 will evaluate this very same combination of Durva and Bev associated with Y90. I think that's it. So thank you very much.
Thank you, Riccardo, for sharing this data with us, and congratulations for this trial, really the first of its kind. Probably will change the game. We have one question. Just wait for the microphone. Dr. Melloul.
Thank you very much. Very impressive study. Congratulations. I'm Emmanuel Melloul. I'm a liver surgeon in Lausanne University Hospital. I have one question. Do you have any data regarding the possibility to achieve a downstaging in those patients and to get access to liver transplant or liver resection? Do you have any patient in your cohort that could finally have enough downstaging to go for liver transplant?
Yes. I mean, as you have seen, to be able to be recruited in the study, patients had to be excluded from the possibility of resection or transplantation at the time of recruitment. However, it did happen that following substantial downstaging, these patients, some of these patients were re-evaluated, and we do have patients who eventually received the resection or transplantation. We are not talking about a large number of patients because, of course, as I said, this was not planned, and we will probably report on these data, in secondary presentations. We definitely have quite a number of patients who received different forms of treatment at the time of progression. So this is an entire, let's say, analysis that will be presented in the coming months.
This means also, Riccardo, that it will be very difficult to get data on overall survival, right? You will get the data, but you will see the effect of the therapy you gave. Sorry.
No, I mean, Jean-François, you touched probably the most important point, right? So I think we all agree that overall survival is the ultimate endpoint, and clearly, we don't want to diminish the importance of overall survival. However, in intermediate HCC, if you combine the expected survival that is currently probably in excess of 26 to 30 months as a median, with the additional lines of therapy that are now becoming available, clearly it looks like planning for a phase 3 in intermediate stage with the primary endpoint of overall survival would probably mean to recruit. There are some estimates that are talking about thousands of patients, with the complication that then the standard of care changes, and you may not be able to basically complete recruitment. So I think we in these trials in the intermediate, not just the EMERALD-1, but also the ones that are ongoing, like the LEAP-12, for instance, or the EMERALD-3, they all have PFS either as a primary or co-primary. And then I think this will be on us as experts once we have all the information, I mean, and all the data to, let's say, perform a critical assessment. Right, we learn that HCC remains a very complex scenario, and individual endpoints are, often exposed to some variability. We have seen different responses, TTP, and so it's probably important to look at the consistency of the different parameters rather than to rely on a single parameter. So this is why I also presented response data, TTP, in addition to the primary endpoint, because of course these studies are much more complex than the time of the shot trial, sorafenib and placebo, overall survival, no other therapy is available. So everything is in a way, once you have designed the study properly, then there will be no confounding effects. Here the situation is more complex, and this is why I think the contribution of experts will be important to perform a critical appraisal and issue some recommendations once all the data is available. But definitely, I think it's a first step. It's a very important first step because for the first time, as you mentioned at the very beginning, we have seen all the attempts, right, of this combination. So it's the first time that we see definitely a signal that the anti-tumoral effect is enhanced. Probably we will have to work a bit to understand, who derives the most benefit from the combination, and so the story is not over, but I think we have confirmation that we are going in the right direction. I think at this point, across all the stages of HCC, from the early, intermediate, advanced, there will always be a discussion around, whether to use alone or in combination some form of systemic therapy.
Well, thank you very much. Thank you very much for this answer. Thank you for your presentation. Congratulations again. And then we'll move now to the next speakers. Thank you, Riccardo.
Thank you.